So happy that we could all be here together, albeit virtually. And hopefully our next wine and dine will be in person. And I hope everyone is doing well and also your families. I want to thank Dr. Marder and Dr. Cosentino for joining us. And I'm so excited for us to tell you about our progress that we have made. In the division that I am part of, my team delivers, as Mary said, integrated women's health. And what we really aim to do is to look at the woman holistically or comprehensively from head to toe. And we like to do this over the life course and just keep the conversation fluid with each individual and focus our care on that individual. So we strive very hard to make it be very different than your average car wash. And so we are very proud that we are starting to deliver that type of care. What I want women to understand is that after menopause, our life does not cease. And actually, we have found much more about life after menopause, and that it's the beginning of a new phase of life. But after menopause, the risk factors and the diagnosis of diseases such as cancer, heart disease, osteoporosis, and other chronic diseases increase. And what we have noticed is that there really is a gap in the care for women after menopause. So we're closing in on menopause research, but moving toward women in the more mature stage of life where there's a lot more expertise and a lot more wisdom, but we really want to take care of everyone as they age so they can age gracefully and the way they'd like to. A few years ago, Dr. Dalton and I were talking about this integrative women's health program, and she pointed out that we really do have a gap in care with women as far as neurocognitive aging. And I do agree with that. I then met Karen and Stephanie, and it has been really a wonderful collaboration. And what we have found is there is a serious gap. We want women to be able to understand what's happening, not only to their bodies, but to their brains, because as we age, that's what we're most concerned about. We have also found that women and men, but women that we work with, are very afraid of neurocognitive aging. And so working with Stephanie and Karen, we came up with a tool that we screen every single woman that comes into our office for a well woman visit annually for neurocognitive issues. And it's a simple 5-question screen. This was developed by Stephanie and her colleagues, as this is something that they do all the time, every day in their sleep. We've honed it after our first couple of cohorts. And not only can we screen women for certain issues, but we can also now refer. And I think that's what the beauty is there's a connection, and we actually are able to connect the dots. And I think making women aware of possibility of any kind of issues occurring as they get older, but also connecting people with specialists prior to presenting with an all-out Alzheimer's or dementia. I think that's very important as we move forward. So I will turn the floor back to Dr. Dalton so we can hear more from them. Thank you so much.
Sorry, I muted myself. Mute myself. Okay, sorry about that. I muted myself. I think I'd know better at this stage. I've been on so many Zooms. I apologize about that. Maybe I need one of those cognitive screens very soon. Anyway, it's a delight for me to introduce Dr. Karen Marder. And Karen is a Sally Curlin Professor of Neurology, and she served as the chief of the Division of Aging and Dementia since 2001. She's focused on the study and treatment of cognitive, behavioral, and motor impairments in a range of neurodegenerative diseases, including Parkinson's, Huntington's disease, Alzheimer's, and other related disorders. She's also the associate director of the Irving Institute at Columbia, where she directs some of the most important clinical research across Columbia and Cornell for patients and families with neurodegenerative diseases. She also provides care for patients and families with these diseases, and clearly patients and families with these diseases need multidisciplinary care. And most recently, she was inducted into Columbia's Academy of Clinical Excellence. So Karen is an example of a triple threat in, as we would say in the medical world, a phenomenal researcher, a fantastic clinician, and a phenomenal educator. So Karen, thank you very much for being with us here this evening, and over to you.
Thank you so much, Mary, for that wonderful introduction. And really, let me say how thrilled I am to be part of this effort led by you and Dr. Rosser. It's really a fantastic opportunity to be able to offer integrated care to women over 60, and in my mind, really long overdue. So I'm a neurologist who specialized in behavioral neurology. And what I thought I would do in these 5 minutes is tell you a little bit about why a woman might come and see me and what the evaluation would entail. So the most common reason a woman might come to our center would be for memory complaints, forgetting names, forgetting words that they want to say. But it's really important to remember that not everything is Alzheimer's disease. We all forget names, we all forget our passwords, we all forget our keys. And when I get concerned, or when people come to see me, is when it's happening more often than usual. So for example, repeating the same story or asking the same questions over and over again in a short period of time, misplacing things or putting them in strange places like in the refrigerator, getting lost in familiar places, having trouble learning new things, or perhaps forgetting to take your meds or paying bills, things like that. So the key for the evaluation, and what we really recommend, is that you have a person come with you, maybe a spouse or a partner or a child, who can also provide some additional collateral history. So what I spend most of my time doing at the evaluation is taking a really good history, because it's very hard. Most of the time, these changes are very insidious, so it's very hard to pinpoint when they began. And what I'm doing the entire time I'm speaking to you is to actually try to figure out whether this is something rapidly progressive or something that's been going on for years. And what I spend also an awful lot of time doing is looking for treatable causes of cognitive impairment that we don't normally think about. So for example, people who are taking medications such as over-the-counter sleeping pills like Benadryl, or benzodiazepines in the Valium family, or maybe medications for bladder dysfunction. All of these can affect your memory. And so we want to look into those as possible causes of cognitive impairment. How are you sleeping? Do you have sleep apnea? Are you snoring? Those are also contributors to cognitive impairment. And of course, mood, which is carefully assessed in terms of depression or anxiety. We look for endocrine problems such as underactive thyroid, high calcium, whether your sugars are in balance. And we also look at vision and hearing, which we'll talk about a little bit later, which also can obviously contribute to cognitive impairment, because if you can't see and you can't hear, you can't process what's being said to you. And I also think about falls. If you had a fall, hit your head, things like that. In terms of the examination, once I've taken the history, we'll often do a screening examination, something called the MOCA, which is probably something you heard about with President Trump, or a mini mental state exam, to get a better feel for whether people have baseline impairment in thinking. So that, again, that's a screening test, and we may later get an additional evaluation, such as what we call a neuropsychological test battery, performed by a neuropsychologist like Dr. Cosentino, which takes a couple of hours. And then I'll do a neuro exam. And so again, this is a non-invasive examination looking for weakness on one side or the other, which might indicate a history of a stroke, or a tremor, or a stiffness, or slowness, which might indicate presence of Parkinsonism, which may be either Parkinson's disease or part of another cognitive disorder. And then I'll order a bunch of routine tests, such as chemistries and thyroid tests, B12, folate, which again may account for the cognitive impairment. And then lastly, we might get an imaging scan, such as an MRI or a CT scan, to look for presence of strokes, or perhaps a meningioma or other unknown or unobvious causes of cognitive impairment. These days, we often, if we're really concerned about Alzheimer's disease, we may get a lumbar puncture or a spinal tap to look for biomarkers, which are really the way that we make diagnoses these days of Alzheimer's disease, but most people don't necessarily need that level of testing. And why do we do all of these things? Well, we think it's really important to get to the bottom of things. And not everyone has Alzheimer's. Many people have treatable causes of cognitive impairment. Many people have what we call mild cognitive impairment, which is a stage we hope we can intervene at. And by getting the people the right diagnosis, we can hopefully get them the right treatments. And then if in fact they are on the right treatments, they may also be interested in participating in cutting edge clinical trials or observational studies that we can offer at our center. So let me stop there.
Karen, thanks very much for that. It certainly gives us, I think, optimism following your short discussion that we don't need to be all so afraid of cognitive screening, and that in many instances you can find something that will be treatable. But finally, let me introduce Dr. Stephanie Cosentino, and Stephanie is an associate professor of neuropsychology. She researches the cognitive symptoms of neurodegenerative diseases like Alzheimer's that you've been hearing about, Lewy body dementia, and frontotemporal dementia. The goals of her work are to differentiate these diseases from one another, and in particular in how to differentiate them from typical aging and memory concerns so that she can improve the diagnostic accuracy and that appropriate treatment can be made. She's worked, as you've heard tonight from both Mary and Karen, to implement a memory screener through our department to establish the clinical and research referral streams to neurology. And very excited that this memory screener, Stephanie, will establish a baseline for our patients that I think will be very beneficial. So Stephanie, thank you for everything you do, and this is over to you.
Thank you very much for that introduction. And it really is exciting to be a part of this panel and event tonight. It's a couple of years that have gone by fairly quickly working on this project with Dr. Rosser and Dr. Marder, and we've worked hard on it, but it's been a really enjoyable and educational collaboration and experience for me. So I thought I would just tell everyone a little bit about my background and the research that's going on in the Cognitive Neuroscience Division of the Department of Neurology. And as everyone's heard, I'm a neuropsychologist, and my interest historically has been in understanding brain behavior relationships. So when we have changes in the brain that occur as a part of the aging process, what does that mean for our memory and our thinking abilities? And in particular, what happens in the context of disease like Alzheimer's disease or other diseases that cause the clinical syndrome of dementia, which is a broad term for changes in thinking abilities that are severe enough to cause a functional impairment in daily life. And Alzheimer's disease is the most common cause of dementia, but there are other diseases as well that can look like Alzheimer's disease in some ways and not in others. And so a lot of the work that I've done in the division is to identify the kinds of thinking abilities that change in the context of typical aging versus Alzheimer's disease versus some of these other illnesses. And one of the most common questions that we get and that we really try to do careful work to disentangle is, what is the difference between memory changes that occur in the context of normal aging versus what are the kinds of memory difficulties that happen in Alzheimer's disease? And so some of my more recent work has been focused on the earliest stages of Alzheimer's disease. Now, Dr. Marder mentioned mild cognitive impairment, where people begin to have difficulties with memory or perhaps language or other types of thinking abilities like problem solving. And so we're trying to understand, even prior to that stage, when individuals come into the office and may have some concerns about their memory, and we do testing, we do several hours of testing, and we see that people perform normally, we're trying to understand what that means. We're trying to understand what is the basis of the memory concerns in everyday life, and are people perceiving something that we're not yet able to measure on our testing? Or is there something else happening in daily life that is related more to mood or fatigue or personality style or views about aging or many other things that might influence the way people think about their memory and perceive their memory function in day-to-day life. So it really is against that backdrop that this collaboration started. And when we began to think about how can we screen memory in the context of a women's wellness visit, we had a lot of different options. And as a neuropsychologist, typically what we do are long memory tests where we ask people to remember lots of words, and then we test them right away, and then maybe we test them again a little bit later. And that really wasn't something that's feasible for the context, of coming in to see your doctor and you have a few minutes in the waiting room before you go in. And so one of the things that we've really started with is this 5-item screener where we can ask women how they feel about their memory, whether or not they perceive themselves to have any memory changes, how concerned they are, and whether or not anyone in the family or any friends have also perhaps noticed some memory changes. And by starting at that level, we hope to capture a wide range of concerns, whether they're just very mild concerns or more significant concerns. And then from there, begin to get women referred, whether in the context of clinical care or research, to opportunities for more extensive memory testing, should that be the route that we think is appropriate. And so we have a lot of exciting types of studies that we're thinking about doing together moving forward. Now we have some of the basic referral streams in place, some of the basic screenings in place, but we think there's a lot to be done in the future. And this opportunity has opened my eyes to some of the more some of the health issues that are more specific to women, and how we can think differently about screening cognitive functioning in women versus men, and what some of the broader scientific and research questions are that we can answer now that we've set up this collaboration. So I'll stop there and turn it back over.
Thanks very much, Stephanie. And we'll start with the questions that we received from all of you before this event. And I'm going to start first with some questions for Dr. Rosser, and then I'm going to move to questions for you, to Dr. Marder and Dr. Cosentino. And if you have additional questions, as I said in the beginning, make sure to put them in the chat and we'll do our best to address them. And I think so far we're doing quite well on timing. We're at 6:22, so everyone has very well stuck to their time. So thank you for that. And the first question for you, Mary, is until what age should a woman see a gynecologist? Is there an age when they should stop seeing a gynecologist?
So that's a great question. I think that it's very complicated. It's not black or white, and it varies with the individual, certainly, and with the resources that the individual has. And many women feel like their GYN is their primary care doctor. So we definitely want people to check in with a provider or clinician at least once a year. Also, in the past, a GYN visit has been viewed as synonymous with a pelvic exam and a pap smear. And we know recently that we do not have to perform a pap smear every single year on every woman. And as a matter of fact, women don't even need a pelvic exam every year. New guidelines actually show that if you've had negative pap smears, negative HPV test over the last 10 years, that you could actually forego your pap smear over 65. If you've ever had any issue with the human papillomavirus or abnormal pap smear or cervical disease, then you need to continue with screening. But it's important that we listen to each person, and many women will come in and say, I hear what you're saying, but I can't leave here without a pap smear. And so that's fine. fine, and we discuss it, and we discuss it every year as new data comes out. But the point of the matter is that beyond menopause, there's so much to a woman that we can look at comprehensively, as we said earlier, and other issues that arise like bone disease, heart disease, and issues that we need to screen for. So I don't think that we can put a time limit on the GYN exam. The other component that we really need to talk about are the vaginal symptoms that happen after menopause. And every woman does not have every menopause symptom, except the majority of women will have the genitourinary syndrome of menopause, which is a very long, rambling term to say vaginal dryness and pain with sexual relations. And so I think it's important that we address women and their sexual health. We also need to look at women's urinary situation as far as urinary incontinence. And I think it's a good idea to start referring women to other specialists if they may need. So we do feel it's very important to see your gynecologist at least every year or every other year.
Great, thanks, Mary. And are there new recommendations regarding mammography and bone density screening?
So this is always comes into play, and it's because our regulatory agencies like the U.S. Preventative Task Force, the American Cancer Society, the Radiology Societies, and the American College of OBGYN actually don't all agree. But we agree in the OBGYN circles and in the radiology circles that we'd like to begin screening women for breast cancer at 40. When do you, and every year after that, and certainly or definitely at 50. And depending on your family history and what the results show, some people think that you can go every other year. But certainly I think most women feel more comfortable doing it every year. So when do you stop? You know, they have said after 69, the cost effectiveness is not as great, but I will tell you when it means one life or your family's life, that's very important. So up to the age of 75, and then after that, every other year. And we work with the radiologists and the patients with regard to their risk. So that I think is really important. Also keep in mind that the breast cancer risk continues to increase into women's 80s. Bone density screening usually is recommended if you have no risk factors to begin at 65. And I will just start right there. At 65, if you have normal bone density or just a slight bit of bone loss and no risk factors, which I'll review, then you can actually have screening every 10 to 15 years. Even though the bone density is a mild form of an X-ray, remember that these kinds of tests are cumulative. So we also want to limit them and not automatically do them every other year. If you have a bone density at 65 and you have risk factors and either severe low bone density or what we used to call osteopenia or osteoporosis, then the recommendation is every 2 to 5 years. The risk factors include increasing age, obviously, a family history of osteoporosis, fractures, multiple fractures with no other cause, a history of using glucocorticoids or steroids for certain diseases, having low thyroid, and a couple that I can't remember. Dr. Marder, don't. Maybe I need the test tonight. But these risk factors I see in almost every person, but I will tell you that we try to keep the span increased so that women are not doing this every other year. Also keep in mind that there are wonderful medications now, and we have experts at Columbia that can talk to women about that.
I clearly didn't follow instructions well because I told you to put your questions in the chat and you put them in the Q&A button at the bottom of the screen. So I apologize for that. So Mary, you mentioned some of the symptoms of menopause, but some of the other symptoms of menopause, like loss of libido and dryness and sweats, can be pretty overwhelming. Are there any new treatments to know about?
So in the hot flash world, or the vasomotor symptoms, so the hot flashes, the night sweats, which are hot flashes in the nighttime, there has been an exciting new class of drugs developed that work in the brain, and bind to receptors in the brain that are associated with menopause symptoms. The problem with this medication is that it can impact the liver. So they are now trying to reformulate this medication. It's exciting because it's a non-hormonal class of medications that does help with significantly reducing hot flashes, night sweats, and therefore improves the insomnia. So that is maybe in the future, but we want to wait until it's perfectly safe. Also, keep in mind with hot flashes and night sweats, thinking about sleep hygiene. I wish there was a better term. There's mindfulness, meditation. People even use acupuncture, and in the right hands, this actually does work. So I would encourage you to look into that. Also, Tai Chi and yoga. So really helping to train the brain to come back to a center, and this is how people write about it in the literature, is really important when it comes to vasomotor symptoms. As far as vaginal dryness and difficulty with intercourse, as you lose estrogen, the lubrication decreases and the vagina gets smaller and a little bit more rigid. So there are many factors that lead to the dryness and the painful intercourse. So you have to see your provider so you can make sure that this is associated with menopause. Are there new treatments on the horizon? They're working with combinations of estrogen and testosterone, which is the male hormone, now to see if that works. I have used that before in practice when it was popular to use the testosterone ointment. And I will tell you anecdotally and in the literature, it's not as helpful as people would like it to be. There are hormonal, predominantly estrogen replacement that you can use vaginally, as well as non-hormonal substances or medications that are actually over the counter. So I think that the research is improving, being mindful and also continuing with a healthy diet and exercise actually improves your overall sense of well-being and improves your libido. So that's what we have.
Great. And I have one final question for you, Mayor, is that when patients present with explained or unexplained pain or other symptoms that lower their quality of life, what do you recommend?
And that's a very complicated question. It's an excellent question because we see a lot of people with unexplained pain syndromes or diagnosed syndromes, including fibromyalgia. I will tell you that the same thing that I spoke about improving your overall wellness appears to help with chronic pain. Also, physical therapy has exploded in the last actually 5 to 10 years. And we even have pelvic floor physical therapists, and they do wonders with helping people with chronic pelvic pain. And I think that they are actually doing great work when it comes to other pain syndromes. We can prescribe anti-inflammatory, pain relief type medications, but people don't want to be on these for long periods of time. So it's about helping people manage their pain on a day-to-day basis, and so that it is not troubling every day, and trying to help them find relief that way.
Great. Well, thanks very much, Mary. And I'm going to move now to Karen and Stephanie, if that's okay. And as I had a little sip of wine when I was relaxing earlier, I suppose it's not too, hopefully it's a little okay for us in moderation, Karen. But my specific question, Karen, that has been sent in for you, are there any recommended supplements or activities to improve the aging process? And we've all seen all the commercials on TV recently targeted at supplements for women for brain health. So would love your thoughts on that.
Well, definitely go ahead and drink that wine.
Okay, thank you. Perfect.
I wish I had a glass. Everything in moderation, I think that's the key. And we know that, for example, 1 glass of wine for a woman or equivalent to 2 glasses of wine for a man is fine and is probably very good for cognitive health, probably on a cardiovascular basis. So absolutely, that's a good idea. But just like anything else, not smoking, but alcohol in moderation is perfectly fine, unless, of course, you don't feel good when you drink or you don't want to mix it with medications that are contraindicated, because that can obviously be dangerous for you in terms of fall risk. In terms of supplements, unfortunately, there is no supplement that I'm aware of that's been tried in a clinical trial. And a clinical trial is really the way we want to test things. It's sort of the gold standard for how we test things. So nothing has really worked in terms of a specific supplement. So vitamin C, vitamin D, ginkgo, those really have not been shown to work. And so we don't recommend them. And we also don't recommend taking health food supplements or that are not approved by don't have this meet the standard of manufacturer grade equivalent, because sometimes there are things in these supplements that are not good and can actually make you sick. What we tend to recommend is a heart healthy diet, and I think Stephanie will talk a little bit more about this. So a Mediterranean-like diet, which is where the wine fits in, of course. But it's the complexity of the diet that seems to be most important for maintaining cognitive health. And in terms of the supplement, I know there was a question about hearing a lot of on TV, I think probably the jellyfish ad about, and in fact, that particular company has been questioned a number of times by the Federal Trade Commission because their clinical trial did not really show any benefits. So I think we really want to stick with a heart healthy diet, American Heart Association, the MIND diet, DASH diet, or Mediterranean diet to get that complexity of food into the system.
Thank you very much, Karen. And Stephanie, there's already a question in the Q&A about this, is how important is aerobic exercise to brain health as you age? And does yoga and stretching do anything for brain health?
It's a great question. And what is nice is that I heard Mary Rosser just say a moment ago that exercise is good for certain other physical conditions, as we all know. And the answer is really the same for cognitive health and brain aging. In general, what's good for your heart is good for your brain. That I think is, if people take away anything tonight, that's an easy one-liner to remember. And there is growing evidence that aerobic exercise may be advantageous to other forms of exercise like yoga or stretching for that reason. For the reason that when we work our lungs and we breathe harder and we improve our cardiac and our cardiovascular health, that we're improving the cerebrovascular health, that is the health of our brain. And so it's a growing field. And so I don't want to say that definitively it has been established that aerobic is hands down better than yoga and stretching. I think the other piece of it is what yoga and stretching does for you as a person. If it improves your quality of life, if it improves your stress level, if it improves your psychological well-being, if it gives you an opportunity to socialize with friends and others, those are all important pieces of your cognitive health as well. And so what we seem to have learned from observational studies is that engaging, whether it's in cognitively stimulating activities, physically stimulating activities, socially stimulating, those all seem to have neuroprotective effects. As Dr. Marder mentioned, the gold standard are clinical trials and intervention studies, which are far fewer. And so we don't have necessarily the evidence to say that a certain thing prevents disease. However, there are many studies showing correlations between improved physical health and it points to aerobic exercise as being linked to lower risk of developing mild cognitive impairment and cognitive decline.
Great. And Stephanie, we talked a little bit about our own screening and what you've worked on Wait, Karen and Mary, when should women ideally begin neurocognitive screening? And do women have a higher incidence of neurocognitive disease than men?
So I'll start with the second question. There is a higher rate of Alzheimer's disease in women than in men. It seems that the overarching reason for this is simply longer lifespans in women. So women are living longer, so there are more women who are at older ages than there are men at older ages. And we know that age is the #1 risk factor for Alzheimer's disease and other dementias. So it may, this increased prevalence of disease in women may simply reflect that longer lifespan. And so some scientists talk about a survival bias, which is that men are dying of other causes earlier. And so we don't see equal rates in older adults. However, there are also some studies looking specifically at whether or not there is a sex-specific difference in biological risk for disease, and whether that may have something to do with how hormones interact with one of the known genetic risk factors for Alzheimer's disease, which is the ApoE4 allele. And so there's a lot of interest right now in understanding that more. So that's the second question about increased risk of Alzheimer's disease in women. In terms of when should women begin neurocognitive screening, I certainly don't have the answer. What I would say is that from what we understand, the risk of Alzheimer's disease really begins to increase after age 65. And so I actually went to a report by the Alzheimer's Association just to see what the most recent data show. Each year, the Alzheimer's Association puts out an Alzheimer's disease facts and figures report. And there's a lot of synthesized data in there that are, I think, very readable and very informative. There's also a website that maybe we can share at some point in the chat. But after age 65, I'll just look at this now while I'm answering. So about 5% of people age 65 to 74 have Alzheimer's dementia. And then in the age group, which is then 10 years later, so 75 to 84, it's about 13 to 14%, and about 35% of people over age 85. So to me, it seems like screening women prior to the age of 60 or 65, you're really going to be having very few people who would ultimately be diagnosed with Alzheimer's disease. So in our studies of cognitive aging, we often enroll individuals who are 60, 65 years or older. And that's when we start to, I would say, screen, quote unquote, people's cognitive functioning. Dr. Marder may want to add to that or have a different opinion.
I agree with you completely. All I would say is because there are so many treatable causes of cognitive impairment, if you notice a change, or if a family member notices a change, I would take that seriously and come into a provider. It doesn't have to be a neurologist. It could be a primary care doctor or a gynecologist, and let them know there's a change over a year that may be meaningful.
Absolutely. I'm so happy you added that, Karen, because I had meant to also add, so there's the idea that there's treatable, and then there's also, we should make the point that there are other diseases of cognitive aging, for example, frontotemporal dementia, that we know has an earlier onset typically than Alzheimer's disease. So absolutely, if the person themselves is concerned or a family member is concerned, then that by itself would warrant an evaluation.
And Stephanie, how do I know what I'm experiencing is a normal part of aging versus something more serious? Or like, in other words, like what are the red flags for Alzheimer's?
Yeah, I mean, I thought Dr. Marder did a really nice job earlier in describing what some of the typical experiences are as we get older. Forgetting people's names is probably the one I hear people complain the most about. Or not remembering where you put your keys. But when something becomes more regular and more severe. So again, some common examples might be repeating the same story over and over again, asking the same question over and over again, becoming disoriented in a place that should be familiar to you. There are a number of things that are probably, these things are less frequent in the context of typical aging than just simply forgetting names, for example. When we do cognitive evaluations, what we do is we look at performance on cognitive tests and compare those scores to normative data. So, data gathered from individuals who are similar to the participant or to the patient in many ways demographically. And we look to see, where does this person's performance fall in the normal distribution of performance. And so we allow for a very wide range of normal performance. There are people who always had fantastic memories. There are people who always have horrible memories. And so what we're really looking to see is whether or not people are performing far outside of what we might consider normal, or what we would have expected them to do given their personal history. And so there's not only the subjective experience of what's normal and what isn't, but how do we tell what's not normal when someone comes in and we evaluate them. And that's what we're doing when we're testing people, is really seeing how different is their performance than we might have expected it to be based on someone's age, education, gender, race, ethnicity. And what I like to tell people is that we design our tests to be very difficult. We do not want people to come in and be able to get 100%, because then we really wouldn't be able to learn anything. So oftentimes people are afraid of cognitive screening because they're worried they won't be able to remember all the words on the list, or they won't be able to name all the things that we show them, and they won't be able to get 100%. That's the way the tests are designed. So I just wanted to take a moment to put that in there, so that people appreciate, if they were to come for a cognitive screening, or if they ever have in the past done that and felt like they might have struggled a little bit, that's normal. And that doesn't mean that there's something severely wrong necessarily.
Great, thank you, Stephanie. Karen, for you, if dementia runs in my family, is at least the question, the way it reads, is a proverbial gun already locked and loaded?
So I'm here to tell you that's not the case. Definitely not the case.
Good news.
So, I mean, there are less than 1% of all genetic causes of Alzheimer's disease are what we call fully penetrant, that if you get the mutation, you're going to get the disease. Alzheimer's disease, for example, is a very complex disease and probably involves multiple genes and multiple environmental factors. And what we've been telling you tonight is that we think there are ways to mitigate against some of those risks that will predict your age of onset. So whether it's good brain health in terms of cardiovascular factors, whether it's social engagement, whether it's the proper diet, exercise, etc., we think that can change things. There are also about 60 different causes of dementia, so you can't assume that everyone in the family has necessarily the same disease. On the other hand, this is the era of precision medicine, so we do encourage, and we have many, many studies on genetic forms of Alzheimer's disease, and we often collect DNA in our research studies because we do think that we will be able to target specific genetic mutations, hopefully in the near future. So it is important to be able to participate in those studies and know your genetic risk. And if you're in a family with dementia, I would strongly encourage you to try to participate in research so that we can find the causes of dementia in your family, for example. But I think, to assume that just because it's in your family doesn't mean you're going to get it. That's for sure.
I like that, less than 1% or 1%. That's a very reassuring number to me. And Karen, you mentioned earlier when you were speaking and giving your intro that you could diagnose Alzheimer's by having a spinal tap. but you don't usually need to do it based on doing your own history. Is there a blood test that you can do for Alzheimer's?
Or not yet. So I guess I did mention the spinal tap. I mean, at our center, for example, we probably do them more than other centers. So it is a more definitive test. So I'm not going to say we don't do it. Blood-based biomarkers are the future. They're not yet ready for prime time. There's one test called procivity, which is not yet approved in New York State, for example, which is a ratio of 2 Alzheimer biomarkers and ApoE4, which you heard about from Stephanie, and age, which gives you kind of a risk profile for how likely you are to have amyloid in your brain, which is one of the pathological features of Alzheimer's disease. So that's one test that is approved in, I think, 48 out of 50 states at this point, and is well correlated with what we call an amyloid PET scan. So having that blood-based biomarker hit the high probability is very similar to what you see in an amyloid PET scan. So not definitive, but a good marker of Alzheimer's changes. Probably more exciting, and again, not yet ready for prime time because we don't know what the cutoffs are for clinical use, are what we call phospho-tau. So there's a phospho-tau P17, for example, that is going to be probably more definitive than anything else as a blood-based biomarker. So those are more to come, but not yet ready for prime time. But obviously, once we have those markers, we'll want to use those instead of spinal taps, and obviously makes a lot more sense.
That's great. We've been talking a lot about, I think we're all interested in mitigation of and prevention of this as much as we can. And this one for you, Stephanie, or what can I do? We've talked a bit about exercise. We've talked about the diet. Are there the brain games? Do they do anything?
So there's been a lot of interesting work looking at whether you want to call it cognitive training, cognitive stimulation. And there are some encouraging studies showing that if people train on a certain type of cognitive skill, for example, making their memory better, or training on problem solving, learning how to solve new problems, it seems like there are beneficial effects of those trainings. And those effects could last up to a couple of years so far. I mean, the studies I don't think have followed longer than that necessarily. But what we see is that people typically get good at what they train on. And those trainings don't necessarily transfer to other cognitive tasks or cognitive tasks in daily life. And so there's promise, I think, for the possibility that engaging in cognitively stimulating activity does train the brain and allow it to kind of create new pathways, or to kind of lay down existing pathways more strongly. But there really haven't been studies linking any of these brain games, quote unquote, or cognitive training or crossword puzzles for that matter, to the prevention of developing Alzheimer's disease. So there have been many observational studies, as I mentioned before, linking engagement in cognitively challenging activities to lower risk of disease and to slower rates of decline. But these are observational, and we don't know the causative factor, and it may be something else about the people that do those kinds of activities and that don't develop Alzheimer's disease, that's truly what's preventing the disease from developing. So I think that my answer is that I would tell people that it absolutely cannot hurt to do these games, to do whatever is interesting to you, to keep your mind as active as possible. That is one component of what seems to build a cognitively healthy life and to support cognitive aging as much as possible. But I wouldn't say that we have data to say that they prevent disease.
Thank you very much, Stephanie. And Karen, for you, you mentioned when you were giving your intro, it was so good in that short 5 minutes, we've all referred to it tonight, about hearing impairment and visual impairment. And can you just share with us the connection between hearing impairment and dementia, if that's real?
Sure. So this is a new burgeoning field. I think that, we don't pay enough attention to hearing. Everyone pays attention to vision. They don't pay attention to hearing. And there's always been a stigma about getting hearing aids, for example. And I think we're learning now from multiple observational studies that people with hearing loss are 2 to 3 times as likely as people without hearing loss to develop dementia over their lifetime, particularly if they develop it in middle age. And why that is may be because of either deprivation of getting that sensory load to the brain, or it may be that you're more socially isolated if you don't hear well. So it's very, very important. And I always try to insist, even before I send somebody for example, neuropsychological testing, that they get glasses and they get their hearing checked. Because if you're yelling at the patient in the office because they can't hear you, that for sure they're not going to process what they're going to hear in normal life. So it's extremely important. And as I said, it's really important now that I think that there are hearing aids that are affordable for many people now that there's some new laws that have passed that allow sale of hearing aids direct to consumer. That's going to make an enormous difference, I think, for many, many people.
That's just so great. And Karen, also, how does dementia relate to Parkinson's, ALS, other neurodegenerative diseases?
So again, that's a whole hour discussion, but we'll make it a minute.
You're very good at making it very short.
We'll make it very short.
You're very pithy. That's wonderful.
There are clear connections. So for example, there's probably the second most common cause of dementia that nobody knows about is called dementia with Lewy bodies. And that is a combination of Alzheimer's changes and Parkinson's changes. So there's a tremendous overlap. When we look at Alzheimer's patients, they have changes of Parkinson's disease in their brain. When you look at Parkinson's patients, many of them have Alzheimer's changes. So there's tremendous overlap, and the treatments and genetics of these diseases are also overlapped. In terms of ALS and dementia, and this is one of Stephanie's expertise, so she can probably comment on it far better than I can. There are mutations in what we call C9, which is a gene that are associated with both the ALS, which is Lou Gehrig's disease, which is a neuromuscular disease causing weakness in the periphery and centrally, with a form of dementia called frontotemporal dementia. So every dementia gives us a clue as to how to treat every other dementia. And these are all diseases of aging. I guess I would be hard pressed to say that there's anybody who donates their brain to science at an older age who does not have some sort of pathology. So we're learning a great deal about the overlap of these conditions, and one informs the other.
And another question I know that could last an hour, but I know you'll be as pithy as informative as you've been all night, Karen. How long can people be functional and independent with these diseases?
No, I always kind of shy away from that connection, that discussion, because I think it's such an individual decision and discussion for everybody. I mean, what we try to do is keep people mobile. What people do not die from dementia, they die from immobility. So I think the diet, the exercise, you don't want people to lose weight, you want them to be able to be mobile, you want them to exercise, because once people are bedbound, that's what gets them in trouble. So to me, a functional person is somebody, as we heard from Mary earlier, who has good bone health, who has good endocrine status, who might enjoy their social life or their sexual life. That's a functional person. So we do everything we can to try to maximize sensory input, brain input, etc., from and try to make people as functional as possible. And much of that is having the right support system and not becoming socially isolated. So we may recommend support groups. We may recommend activities that they can participate in senior centers, but to try to engage as much as possible, get a good night's sleep, and enjoy your daytime.
It's great. Karen, you've been so informative. Stephanie, quick question for you. Do we know anything about the subjective awareness of these diseases? Are people aware that they have dementia? And if you could keep it as short as possible.
Sure. Yeah. So I would say yes. Some people do know and some people don't know. And that's something that is one of the most striking differences across patients in the earliest stages of disease. So I would say that the idea that if you have Alzheimer's disease, you don't know it, I would say that is not accurate. That's true in some patients, but not all. And also the misconception that if you're worried about your memory, you have nothing to worry about. That's also not the case.
And another one for you, Karen. I'm concerned about becoming a caregiver of someone with a neurodegenerative disease. How do you see loved ones cope?
Uh, you know, I try to spend as much time with the caregiver as I do with the patient, because the caregiver has the brunt of many cases has the brunt of responsibilities. And I think it's really, we know that depression is much more common in caregivers than in the general population, and they may become socially isolated as well, because it's harder. For example, if someone has Alzheimer's disease, you may not socialize the way you did previously. So it's isolating for the caregiver as well. So you want to spend time with the caregiver, get them support, have them go to a support group, have them have time off, have them have some respite from family members or friends. And I always tell them they have to pace themselves, because if they're not there for their loved one, then then we have to worry about what will happen to that loved one. So it's really can be a crisis, and you have to take that person's well-being very seriously.
You know, we're at the top of the hour, but there's a lot of questions in the chat. And one in particular I thought might be useful, Karen, if you would answer. You said about sleep medications, that can impair memory, and that's something you would really want to bring out in the history. There's a question in there about how many milligrams of Valium and whatever other sleep medications could cause this, because I think many women as they age take medications for sleep.
Yeah, and again, it's a very individual decision on how much somebody is taking. So, what 2 milligrams of Valium for one person may be they may be very sensitive. Another person may be used to 10 and it's not such a problem. But I think what's important is to go through all those medications people are taking, and people don't always realize that the over-the-counter medications that may not have been prescribed may be causing their problems as well. So I think, as I said, Benadryl is a very common culprit for causing memory problems. Anything that's what we call anticholinergic, which is the opposite effect of what the medications for Alzheimer's do. So you may be taking an Alzheimer's medicine, and if you're taking something like Benadryl, you're counteracting the effects of the cholinesterase inhibitor. So I think with your provider, whether it's your gynecologist or your primary care, important to bring in everything you're taking and go through it one by one.
And Mary, for you, there's a question about, is there any conclusive research about women with a history of migraines with aura still being advised not to take HRT for menopausal symptoms? And certainly all of you can weigh in on that, Karen, to be interested in your response too.
So I will just start very, very briefly and say I work very closely with neurologists that specialize in headaches specifically. And the research is not as conclusive for hormone replacement therapy. The doses are much lower than that in combined oral contraceptives. And we do know that women that have migraines with aura have an increased tendency for blood clots and strokes. So we don't prescribe birth control pills with estrogen and progesterone. The levels of hormone replacement therapy are very, very, very low. And again, I work with the neurologists who usually recommend a trial of it if there is nothing else that women can use, and then we go from there. So I don't know if Karen has any additional information, but the research is not conclusive about HRT.
And I agree completely.
Great. Well, I think we have just gone slightly over. There's one comment in the chat from one of our Women's Health Council that this was great, but clearly we need so much more. And I think the interest in this has been phenomenal. For me, it's been very educational. And honestly, I'm so proud that this is happening in our department, this wonderful collaboration, that we can do this for women and be available to women. And I know that the development office will send out the contacts for everybody after this. And just very, very grateful to Stephanie and Karen, who collaborate so well with Mary in our department. And thank you so very much for your time tonight. And I know Sarah Bellinghurst is on, and I thought Sarah might like to say a word, as she is the leader of our Women's Health Council. Sarah, are you able to say, to come on and say anything? Maybe she's already left. Sarah was here earlier, I know that.
I'm
But
here.
oh, there you are, Sarah. Yeah, Sarah.
Oh, hope's
Of
come
course.
to the rescue. No, I just want to thank you all. I mean, this has been fascinating, but I've got a lot of questions, more that I'm sure all of us could ask about what it is for people. Most women end up by being solitary, being widows, being alone. And I think that this group plus Catherine Monk would be amazing to discuss all of that about part of aging in the future. But there are many, many questions, and I really would like to ask everyone who's watching this today to send in ideas for other things you'd like to discuss, whether you want to continue with this. I know that the people who went to the perimenopause wine and dine very much want to continue into menopause, especially with Mary Rosser. And I just think that these are terrific programs. And I want to thank all of you so much for participating in this. It's really important because, you know, women, the other day they did an extraordinary panel about women's heart problems. And they're so different from men, and it's so important that we all know about this and aware of it. So Mary, thank you for spearheading all of this, and thank you for your really extraordinary doctors and everything you do to put this together.
Well, I just hope that maybe we'll be together soon and we can spend longer talking about this, because I could see a wonderful evening with Mary and Karen and Stephanie, where we have a little bit more time to talk informally about all of this. But
yes,
thank you, Sarah, for suggesting we do this, and to everybody on the council. And we're just 5 minutes late, but thank you very much, all of you, for your participation and being with us this evening.
Thank you very much, everyone. Thank you, Mary. Bye.
Okay, bye. Bye.